A little history on how Mendocino County, the earliest thing I remember about KDA is we were in a kind of a different situation. Our board of supervisors had decided they wanted to contract out our community mental health completely. Adults, children's crisis, the whole gamut, other than administration and UR, QI, and that type of thing. So that was in the throes, and it was really coming down to the wire of the transition. And a clinician happened, he came in my office and he said, hey, we're getting ready to lose our job here. So if there's something you could do in CWS or something for us, that'd be it'd be helpful. And not something I could do, but if I had any ideas. So I happened to go in Brian Lowry's office at the time. He was the deputy director of CWS and interim assistant director of the agency, and which is basically the sole services director. And we talked a little bit about, I asked him what he would do if he had some mental health clinicians under his charge where he could just basically direct them and do whatever he wanted. And this is his language, not mine. I don't swear. He goes, Doug, I would kick ass. So I said, okay, if you can lower foster care costs, if you can help kids have a better life, prevent some homelessness in the future, why not? So we'll try it. So I went and asked Stacy Cryer, our director, for permission, and I explained that to her, and she looked at me like I was from Mars, like, of course, let's try it. So I went and started writing up and researching what we can do. And what it ended up, got ahead of myself here, sorry. Oh, and in the conversations with Brian, though, the biggest point before I even started, he wanted to make it very clear that the importance was being able to fund services that don't necessarily qualify for 4E or Medi-Cal. He wants to be able to provide services that work, not what fit the mold. So unfortunately, that works against my grain because I was raised to go for functional value, which is get that federal money. So, and then we had another hurdle too, because every clinician we've ever had working for us has been driven in their head for the last 8 years that Medi-Cal billing percentage is the only thing that matters. So it's going to be quite a turn. And that's how we designed the system. What we ended up doing is we ended up contracting out on the first side for community mental health services. We ended up contracting out again adults, children in crisis, and we used 2011 realignment and MHSA. And the thought was this is basically it's kind of community money. It's easily identifiable. It's what everyone was focusing on in our county, and 91 realignment was kind of being ignored. And the goal of the community mental health, especially mental health services, was to maximize federal FFP, because basically what they're in the game now is they have to make their money work. They on the community side, need to leverage that money because they're not going to make it to the end of the year on the match money we gave them, which is again limited by 2011 realignment and the MHSA. For the KDA program, on the third slide actually, which is the Child Welfare Services, Foster Care, KDA, and CalWORK services, we use 91 realignment, and the way the model there is that's considered kind of county dollars, and we use the social services 91 realignment qualifies because it's for CWS clients in cases, and then the 91 the mental health realignment qualifies because we're providing mental health services to kids. But again, we're not interested in, we're not interested in FFP. We're interested in just providing the services. As we get more sophisticated and as we get our program running and start building on it, the goal is to be able to try to turn any service into a Medi-Cal billable service, but have it be contingent on the service is the important thing first, and hey, if you can knock out Medi-Cal 2 while you're at it, go get it. And that's what we're doing. And we're also, too, it's included the SB 163 RAP program. And it's not quite, but it's almost one big RAP program is kind of the goal. So that's it for fiscal.
So how we implemented on the program side was once the county contracted out the mental health services, the staff in county mental health were reassigned to child welfare services. So they're actually housed with us, although they're still county mental health department employees. So we got some clinical supervisors, clinicians, rehab specialists, and staff assistants. We already had an existing wraparound program, and so we housed that staff with our wraparound program staff. We went through all of our child welfare cases through the end of September. We had about 355, and 98 of those met the subclass criteria, which was about 27%. Back in May, my vision when all this happened was that we would serve all of the kids through wraparound. But one of the things that came up was currently we don't have the staff internally to do that. And I think, Cheryl, the quote you started out with this morning about if you want to go fast, you'll go alone, but if you want to go far, you have to go with others. And that's currently what we're struggling with, is bringing all of the community providers with us to help serve all of these kids that meet the subclass. So currently we have a good process, or at least a solid process worked out for the front end. As kids are coming in, our clinicians are screening, doing the KDA subclass screening and a mini assessment that covers diagnosis, all of the things that need to happen for Medi-Cal, as those referrals are promoted to open child welfare cases. So we have collaboration between our emergency response teams and our clinical RAP team. And so they do those screenings within 2 business days, and that also includes the CANs as part of that assessment. If the child's coming in and they've already received or been receiving some mental health services, our clinician is working with that mental health provider to do that assessment and screening. Once that initial screening's done, we refer the child to the Redwood Quality Management Company, which is the company that oversees the contracted out services, and they assign it to one of their providers to do a full biopsychosocial assessment within 7 business days of the referral. And the community providers are the ones that will actually provide the mental health treatment, so the therapy services. They can provide rehab. We also have staff to provide rehab services. And then if no mental health needs are indicated, our mental health staff assistants are tracking them so that we know when they need to come up for their annual reassessment. So for the kids that are determined to meet the subclass, we initially look at serving them through our wraparound program. So that goes before our county multidisciplinary team for that approval. If that's approved, then the clinician and the social worker meet with the family, discuss the wraparound program, the core practice model, confidentiality, obtain all releases of information. We're also a county that uses safety organized practice, and so we've blended that in with our wraparound program to do that before the first child and family team meets, to help really focus the RAP team on what the child's safety issues are, the harm and danger that happened, the strengths, and what needs to happen next. And then they begin working with the family. Our wraparound facilitator is also the ICC coordinator. And they work with the family to develop the meeting schedules, and then we use the CANs every 90 days to continue to measure progress and the effectiveness of the plan, and continue working with family until the goals have been reached, and then develop a transition plan. So the big areas that we're working on, I said we're still addressing how to serve all of our kids because we don't have the internal staffing, the internal mental health staffing. And then also another challenge we're looking at and working through with our organizational providers is really having that mental health provider that's providing the mental health treatment be part of that team. There are a lot of scheduling issues, so we're working through those, and how often we need them to be at child and family team meetings. And then for the cases that we're looking at the organizational providers facilitating that child and family team, so providing the ICC and IHBS, really ensuring that they're embracing the core practice model, teaming with the social worker, having that sharing of information, because that hasn't been their traditional role with children and families. And then another area that we have not addressed yet that we are going to be working on is how to serve our out-of-county kids that are placed with relatives or a parent or a non-related extended family member in terms of how to manage those cross-county lines, especially when significant distance is involved, when you want to be teaming with that child and family and the mental health providers. And then also, we have a placement unit that is also now working with our clinical team to help monitor those kids coming out of residential treatment back to our county to make sure we're screening them and having services in place as they are coming back to Mendocino County. So for me, what has helped with this process is having regular meetings with fiscal, our quality assurance teams with mental health and our organizational providers, and just bringing everybody together to talk about all the issues. And it really is a work in progress, and it's been an exciting, fun time to develop this, but it's a lot of work, and just really having everybody on the same page and addressing the same issues all at the same time has been helpful.
So I'm sitting up here and I'm listening to these folks talk, and I'm very proud of our Mendocino County team. And I don't think that there's one thing that I could say we could hang our hat on that other counties could go, okay, we could go do that. All the counties in the state are so different and unique. But I have to say, I am kind of stuck on Doug's comment of, I said we would kick ass. I think we have, in a way. One of the things that I think is needed, and that we're very fortunate to have in Mendocino County, is a good working relationship. Doesn't mean that we don't disagree with the mental health director or our foster family agencies, executive directors and such, but we're able to, and have been for a long period of time, been able to sit down with those groups and be able to come up with ideas and solutions and move through some tough issues. So if there was one thing I would say to hang your hat on, is that if you can have a mental health director and an agency director, we have Stacy Cryers, our agency director, be able to support your teams about how they're going to go and do business within implementing KDA. That's important. If those folks aren't educated into what people are having to do, sort of boots on the ground, then you have, regardless of the size of your county, you're going to have a much more difficult task. Our staff expect that, we can be out there and support what it is that they need to do their work. We're very fortunate that we were able to take folks that could have been laid off because of this RFP and bring them into child welfare. It's something that I had wanted to see for a long time. The fact that Doug heard me when I said in the other components, at least for Mendocino County, would be, if all we're going to do is focus on allowable and billable, or allowable and not billable, I learned all kinds of things this last year about Medi-Cal and billing that I wouldn't have thought even existed. But if we were going to focus on that, it wasn't going to work. Because if I have a kid that's in a crisis that needs to go to a level 14 or come back from a level 14 from a hospital or whatever, I want a rehab person or I want a clinician in that car, regardless, with that social worker, regardless of whether it's billable or not. And they said, okay, we can put a system in place funding-wise that will be able to accommodate that, but we do want to draw down dollars when and where we can, but that wasn't our first and foremost priority. The children and families that we serve and what they needed became the first priority. So with that, I'm very proud of our staff. Gina has done a fabulous job as the deputy director. She came in February, took over for me, and the work that I was doing, she's enhanced that much more. And I can't thank our fiscal team and our mental health partners in the fact that we are where we are today. A lot more work to do, but I think we're well on our way, and I do think Mendocino County is a good county for other people. If you want to talk to us and see and get a little bit more insight, we'd be happy to share some of that information. Thank you.
Great. Let's give Mendocino a hand.